Welcome to Bullet Point Nursing. My name is Dr. Goldstein. In this lecture, we're going to go through hematology and oncology medications. Let's start with a little bit of background on hematology. First, let's understand anemia. Anemia is a state of reduced red blood cells, and the test that we use for this would be a CBC, which includes the red blood cells, the hemoglobin, and hematocrit, all of which I would expect to be down in anemia. Plus, for iron deficiency anemia specifically, we have another test called an iron panel, which includes an iron level, a ferritin level, and a TIBC. A few different types of anemia. There's iron deficiency anemia, B12 deficiency anemia, folate deficiency anemia, and hemolytic anemia. There are some very common, very generalized signs and symptoms of patients that present with anemia. This includes fatigue, being pale, weakness, trouble breathing, dizziness, and tachycardia. I should rephrase that. It's not really trouble breathing. It's that they can't catch their breath. Let's talk about the first medication, which is Epoetin alpha. Epoetin alpha is actually erythropoietin. Erythropoietin is normally produced by the kidneys in a healthy functioning kidney, and it stimulates red blood cell production. In certain types of anemia, patients may be deficient on their red blood cell production, such as having a lack of erythropoietin due to the kidneys not functioning properly, so not able to produce that erythropoietin. This drug will replace that erythropoietin that the body should have. It does have a very much tested on, especially in nursing school, black box warning, which is that this cannot be given to a patient that has a normal hemoglobin level or a hemoglobin level above 11. Why would a patient want to take this if they have a normal hemoglobin level? Because it can increase our red blood cells, and increased red blood cells can lead to increased stamina, increased energy, things like that. For that reason, this might be abused. That's why it has a black box warning. Absolutely not to do that. Why not to do that? Because if we do this, if we give this to a patient that doesn't need it, even though we would increase the amount of red blood cells, that would actually increase the amount of red blood cells too much and make the blood really thicker than it's supposed to be, which can cause clots, which would be a major adverse effect. The side and adverse effects of this drug includes hypertension, arthralgias, nausea, vomiting, and fever. This medication takes several weeks to get its effect, so it's not like we're going to give the patient the medication today and tomorrow check a new CBC and see if it improved. We're not going to check a new CBC usually for about a week or two or even longer. And this medication is not available orally. It is given by injection. Next, we have filgrastim. Filgrastim stimulates the production of neutrophils, which hopefully you recognize is a type of white blood cell. What do we use this for? We use this to decrease the risk of infections in patients who have suppressed immune systems, such as those undergoing chemotherapy. The side effect of this medication is that it can cause pain in your bones. This is another medication that is not available orally. It's given parenterally, and this medication also takes several days to take its effect. And like I said, most common case we give this is to cancer patients who are undergoing chemo, which is crushing their immune system. So this boosts their immune system. Next, we have iron. Iron is also known as ferrous sulfate, and this is something that's an element in the world, and it's required of us in order to produce hemoglobin. Hemoglobin is what carries our oxygen in our blood, and hemoglobin is made out of iron more than anything else. Iron is given to treat iron deficiency anemia as well as to prevent iron deficiency anemia. Now, iron does have a number of side effects, specifically constipation and dark stool, plus it can also cause some nausea. We do have several tips to avoid this, which we'll get to in a second. This medication also is known that it can cause a fatal overdose in children. When we take iron, it is meant to be taken on an empty stomach. Many patients are not going to want to take it on an empty stomach. They're going to say, if I take it with food, I don't get the constipation. The problem with that is that's true. Taking it with food won't give you constipation, but it also won't give you the effects of iron. Taking it with food can cancel out a whole bunch of that dose. So we always want to take it with an empty stomach, even if it means taking a lower dose in order for the patient to be able to tolerate it. Patients are going to be taking iron for several months when they have iron deficiency anemia, when we're treating it, but generally they're going to start to feel better in just a few days. When patients are taking this preventatively, they're going to be on a set schedule, such as every day, every other day, or several times a day, whatever it is. When patients are taking this medication, very often it is dosed, as I just mentioned, as possibly a dose every other day or every third day. And this is mainly to prevent the side effects of constipation. Patients should also be recommended, if they're taking iron, that they should try to supplement the iron with dietary sources of iron, such as meats, fortified grains, certain fruits, vegetables. Vitamin C can increase the absorption of iron. So when a patient is taking iron, they may be recommended to take it with vitamin C. However, I want to caution you that this will increase the absorption. So if they're consistently doing this, they're actually getting a higher dose than we would expect them to be getting. So the provider is definitely going to need to know about this. I will tell you this is a touch confusing because some nursing textbooks say don't take it with food, don't take it with anything, don't take it with vitamin C because that's going to increase the amount of iron that you get out of your dose, and your provider may not have wanted that. However, other textbooks say to take it with vitamin C in order to increase the effects because that's a positive thing. So I'm just giving you the information, clarify with your school what exactly they're going to want you to know. But generally speaking, it is a positive thing to take it with vitamin C as long as the provider knows that that's happening because they need to recalibrate how much iron you need to be taking. Also, please educate your patients that their stool will turn black so they don't freak out and come back running concerned about that side effect. Next, we have B12. B12 is called cyanocobalamin, and this is a required component for red blood cell creation and for DNA synthesis. If a patient does not have enough B12, they have what's called megaloblastic anemia or B12 deficiency anemia. B12 is available in a few different routes. However, if a patient presents with acute B12 anemia, they are going to be treated with IM injections. It's actually very interesting because it's a red liquid in the vial. IM injections of cyanocobalamin. It's one of the only times you'll have a non-clear liquid medication that you're injecting. But once patients are stabilized, they can be treated with other routes. Intranasal is becoming pretty popular. Generally, if patients have megaloblastic anemia, they are going to be continue treatment with this for the rest of their life. Now, I want to back up a second because there's two different types of being B12 anemic. Number one is we're not getting enough B12 in our diet. And the reason for that would be because all dietary sources, or almost all dietary sources of B12, are going to be animal products. So someone who's on a strict vegan diet, no eggs, no meats, nothing like that, is not going to get any B12 naturally. However, most patients who are on a strict vegan diet, they know to supplement with either a supplement of B12 or a lot of the foods that cater to vegan lifestyle are already fortified with extra B12. Some common things are cereals and breads and other things. So if a patient is going on a strict vegan diet, they do need to be educated that they need to supplement with vitamin B12, either through fortified foods or just taking a capsule a day. However, the other type of B12 deficiency anemia is not where they're not getting it in their diet, but rather they are unable to process it. Not to go too deep into the patho, but patients are, all of us have something called intrinsic factor or IF in our GI system, and that is responsible for the body using the B12 that we eat. If a person doesn't have that, the body cannot use any of the B12, so they're going to end up with no B12 no matter how much of it you consume in your diet. That's the type of anemia we're talking about when we talk about that the treatment's going to need to continue for the rest of their life. Now we finished hematology, let's move on to oncology. Before we go any further, I do want to clarify one point. When we move on to cancer, there's three types of treatment for cancer. There's radiation, there's surgery, and there's chemotherapy. Chemotherapy, by definition, is the pharmaceutical treatment of cancer. Another point I want to tell you, chemotherapy is a very, very specialized field. In fact, oncology as a whole is a specialized field because no one really, other than an oncologist, is going to have anything to do with the treatment of cancer. So for that reason, I'm not going to go too deep into any of these medications, but let's go through some basics. Chemotherapy means medications that are used to treat cancer. Cancer are extremely rapidly dividing cells, and that's a lot of the problem with managing cancer. Plus, there's the fact that we have to get rid of every single last cancer cell in your body, or else over a period of time, there's a very high chance that they're going to continue to replicate and cause the same problem over again. Many chemotherapy drugs require the use of specialized protective equipment, such as nitrile gloves, to prevent your skin touching the medication. There is also something called radioactive isotopes, which I don't think you'll get tested on in pharmacology, but I did throw it in here. Those do require handling and disposal precautions, such as shielded garbage bins, etc. Again, I don't think you're going to have to know that for pharmacology, but I did throw it in there just to give you a heads up. Next, here are 4 common side effects to all chemotherapy agents. I'm sure there's exceptions, but this is a safe rule to memorize for all of them. One is teratogenicity. All the drugs we're about to talk about should not be taken while pregnant or planning to become pregnant. If someone is diagnosed with cancer and at the same time they're pregnant or they find out they're pregnant, that is a decision them and their provider are going to have to make about how to continue on the course of treatment. Next, nausea and vomiting. Almost every chemotherapy agent is going to cause nausea and vomiting. And a heads up, this is some of the most powerful and unimaginable nausea and vomiting that patients can ever experience. Because of that, we are very aggressive on managing their nausea. We always pre-treat these patients who are known to have nausea from their medication with nausea medicines such as ondansetron, which is Zofran, even before they start to become nauseous and even before they get treatment, just to head it off so that it's not as bad. Plus, we have a bunch of other medications that we use for nausea, specifically in chemotherapy patients, such as steroids and cannabis and other items. Again, I'm not going to get too deep into this. I'm just giving you a heads up. Next, immunosuppression. Almost all the chemotherapy agents are going to suppress your immune system. So for nursing school exams, make sure you understand that means that we're going to be very aggressive if we find out that they have a fever. We're going to also be very careful with making sure that they prevent infections in any way, shape, or form. And finally, alopecia. Alopecia is loss of hair, very common side effect from chemotherapy. Next, let's talk about the actual drugs. The first one we have is the alkylating agent. This is cyclophosphamide, and this one interferes with DNA replication. Again, I'm not going deep into these. Next, we have the anti-metabolite methotrexate. This is the only one I'm going to go a little bit into because methotrexate is probably the most commonly tested on cancer drug because we use methotrexate in other places. We use it for rheumatoid arthritis and autoimmune diseases. It's also used to induce abortion. In fact, it's the recommended agent on a lot of guidelines to induce abortion in patients that have a ectopic pregnancy. Methotrexate works by blocking folic acid, thereby inhibiting DNA synthesis. This medication takes several weeks to work for RA. With chemotherapy, I'm not sure exactly the onset of how long it works. And this medication is often used as a first-line drug for rheumatoid arthritis. Again, we're talking today about it for cancer. It is teratogenic, as we previously mentioned. Because this is a very powerful drug, it does have a ton of side effects that, again, I'm not going to go too deep into in this lecture. Next, we have the antimetabolite 5-FU. This one interferes with thymidine synthesis, which interferes with RNA synthesis. And next, we have the anti-tumor antibiotic doxorubicin. This medication interferes with the synthesis of DNA and RNA. This one is known to be cardiotoxic, so be very careful with monitoring your patient's cardiac levels or cardiac system, and also being careful giving this to patients that have underlying cardiac conditions. Please educate your patients that this can turn your bodily fluids over to a reddish color, so again, that they don't freak out when that happens. Next, we have the plant alkaloid vincristine. This medication works by inhibiting cell division and RNA and DNA and protein synthesis. And this one has a notable side effect of causing neuropathy and other central nervous system signs and symptoms. The next one we have, I have no clue how to pronounce it. I'm not even going to try, but it starts with a T and it's up on your screen. This medication prevents DNA repair by stabilizing single-strand breaks leading to DNA damage. Again, this is another cancer drug. I'm not going deep into these. This is a very tiny part of your pharmacology course and the pharmacology on the NCLEX. Next, we have anti-estrogen. In fact, I would say chemotherapy agents will probably be one of the smallest portions, if not the smallest, out of all the sections of pharmacology. Next, we have anti-estrogen. The drug over here is tamoxifen. This one is a little bit more commonly tested on, a little bit more well-known. This blocks estrogen receptors in breast tissue. This is used for the treatment and prevention of breast cancer. This does have two black box warning. One is that it can cause endometrial cancer, and the other is that it can cause thromboembolic events, which means things like DVT or pulmonary embolism, which means patient education. They need to immediately report if they develop a shortness of breath or any of the signs of a DVT, like swelling on the leg, things like that. This medication also has a side effect that it can cause decreased libido, hot flashes, and other endocrine hormonal issues. Next, we have the calcineurin inhibitor. This is cyclosporin. This medication is used for immunosuppression to prevent organ rejection post-transplant, plus it's used to treat cancer. It has a whole bunch of side effects. I'm not going to go through all of them. It has a whole bunch of black box warnings, so be very careful when giving this drug to any patient. That's what we have for hematology and oncology. Please subscribe to our channel, like our videos, reach out to us if you have any questions, and have a great day.